All right, my topic is the difficult axilla, and that's kind of a hard topic, I must admit. I had a hard time with this talk. So I thought I'd give you some information that I know is just coming out on top of that may be helpful for you and you can take back to your own institutions. And one we're going to talk about, there's going to be new Commission on Cancer standards that are coming up, and these are going to be kind of important if you work at any cancer center and things that you need to do. And one of the reasons I think that these are so important, because if we adhere to these standards, we have better outcomes, meaning the patients do much better. And of course, we always want to do an R0 resection. I think R1, R0 is the best. And the number of lymph nodes that we need to examine are also important. So if we are looking at a tumor that's T1 or T2, T3, we'd like to at least take out 2 lymph nodes. And if we have someone who has a pathologic N2 or N3 tumor, we should take out at least 10 lymph nodes. And this shows the adherence, and overall we're only good about 78%. And as I said, why is that important? If you look at overall survival to these patients when we adhere to these standards, you can see there's a very significant difference. So I think these are indeed important. So this new CoC Surgical Standards is coming out, and they're going to talk about all the critical elements that they feel are going to be important. And as you know, as we get measured on all these quality measures and all these things, I think we need to know these. And they're going to tell you what you need to do for the identification of sentinel nodes, the techniques for injecting, pre-incision evaluation, and node removal to limit seroma formation. So I know this is not just sentinel nodes, but I thought I'd throw this in. A sentinel node are defined as nodes having uptake of a localized substance, that's a radioactive tracer and or color dye, that has been previously injected into the affected breast, a node to which an afferent colored lymphatic travels. So if you have a lymph node that's not blue yet, or not radioactive yet, but, well, you can't tell by radioactive, but if you see a blue lymphatic, afferent lymphatic going to a lymph node but has not yet turned blue, that is also now defined as a sentinel node. Any dominant nodes that are suspicious, again, this goes to palpating the axilla. So you have to, what I tell my residents is you have to do a physical exam intraoperatively. You have to put your hand in there and feel around to make sure nothing